I'll start with one case, one of my cases only. So this was a 80-year-old lady with a bilateral knee replacement done about 10 years ago. Had a fall in the bathroom, had a bilateral periprosthetic fracture. She is diabetic, hypertensive, ischemic heart, asthma on steroid inhalers, which all of you know cause severe osteoporosis, with a DEXA scan of overall value of -4. And these are her X-rays. It's a bilateral periprosthetic knee. Now I want to ask the panel, what would be the plan? She's quite comorbid, as you can see. And these are the X-rays. Yes, starting from Abhay.
She's broken both sides.
Yeah, she's broken both. Broken both. Very poor bone stock. The prosthesis hold is questionable.
Yeah, so the question...
And overall bone density is -4, as I told you.
Yeah, so the overall question is that one, the level of the fracture, second, the degree of the comminution, third, the degree of osteopenia, and fourth, the stability of the implant. So the stability, if one does not have enough good bone left behind to stabilize this particular implant, then the choice of doing a fixation will eventually land up into another failure. And what we can see here is that probably the joint apparently is well fixed, but the quantum of bone stock left behind with both the sides is not so great.
Perfect.
And in an elderly patient, it's best to revise. And I would go on to a hinge in this case, because the level of the fracture and the degree of comminution is walking into where the cruciates, collaterals are attached. So obviously,
you would change it. You would revise the joint.
Yeah, so I would need to revise this, and fixation would not be a very strong option in my book for this particular situation.
So that means you will choose a tumor kind of a prosthesis?
Yes, I will use a hinged implant, which will take care of even if the collaterals are not so great. In an elderly person, it will hold.
Rajiv?
Sometimes you might be surprised because these X-rays do not tell the whole story. So I would be ready with everything. I would be ready with a fixation, which would be a 2-column fixation if I'm going to fix, or revision. Everything ready on table.
So if at all
do a traction view on table, see if I have enough bone. Quite often, this whole thing is crunched in and flexed, and when you distract them out, you see there's enough bone. I could, the left hand, this corner, one which I'm seeing, I think that I'll get away with a both sides plate. With that has got enough lateral column going up. So normal lateral column plate and a medial column plate. Other one, I'm not very sure.
If at all fixation, you would think of a bicolumn.
There's no doubt about it. Bicolumn fixation.
Chandak, sir?
Same as he said, a good traction X-ray and bicolumn fixation.
Okay. Atul, I'll not ask you since you know it. Harshad, anything different? Fixation or replacement?
No, the right looks amenable to fixation, the left does not. So I would be very careful on the left side for fixation. I would err more towards revision on the left side.
So fixation on the right and revision on the left.
Yeah.
And what kind of fixation?
So nobody wants to do CT scan? Yeah, but we have metal reduction CT. We have get some amount of CT. We'll get to know something.
So instead of CT, we have some oblique X-rays here.
So even when the CT, now sometimes you don't get adequate information. You have to keep both ready. CT will not give you a definitive. It definitely gives you more information, but you can't rely on that. You have to keep both ready. You may have to revise it. You may need to fix it. So both have to be kept ready whenever you do these kind of cases.
Okay. So these were primarily the questions. Whether you do both legs in the same sitting or staged, whether you do a nail, whether you do a plate or a combination, single plate, dual plate, or of course the final option, which is to revise the whole distal femur, the whole prosthesis. So we heard various options. Anesthetist said you cannot do both single sitting. She was 80 years old with multiple comorbidities. Yes, Harshad, you
Yeah,
have-
even I would be very reluctant to do both single stage,
Yeah,
because each itself is a big job, and doing two big jobs on the same day would be a little bore.
right. So I also felt the same. The anesthetist also felt the same. So I did the right first. Obviously a revision prosthesis was there on the table, but like what Raju suggested, when I opened, there was enough bone, and the prosthesis was also well fitting on that bone. So I decided to fix it. So I put a distal femur nail right up to the lesser trochanter with a medial plate, because the medial condyle, if you see the right sided x-ray, the medial condyle was reasonably good, and I could fix a medial plate on that side. So it was a nail plate combination, and 1 week later on the left side, because both the condyles were shattered, I did a combination, what we demonstrated yesterday, a similar kind of a fixation. But the point to note here was that the bone was so porotic that I had to use one femoral head per condyle of allograft. And this was one of the earlier cases of our bone bank, and I used one entire femoral head on the left and another on the right. Is the panel happy with fixation, or anything would happen?
Yeah, yeah.
So,
The
a great
implant did allow you to put a distal femoral nail.
It's
Not all implants permit that.
Yeah, so it had a box where I could get my nail through.
So that's what I was alluding to. So one, you are implant, you need to know what implant there is. So you need to have a box.
Yeah.
And it's a greatly done job. The only thing that comes to mind in this situation is that a very important factor in how we and what we treat with these especially elderly comorbids is that we need to get them back on their feet as early as we can. So with a bad quality of bone, the chances of her getting back to her feet become lesser and lesser, and it's going to take a lot more time.
I know. So we started with wheelchair mobilization immediately. Obviously, she could not put weight on either of those, but then she was out on a wheelchair and moving around.
Chetan,
Yes.
one important point which I have learned is if you are doing a nailing, just not only know the companies you have, also have inserts ready for it. Because I once started nailing it and that insert was getting in the way. So then I had to wait to get insert of the company. So when we are doing if you have planned a nailing, get inserts ready, because you might have to remove the insert, nail, and then reinsert. Once you have taken the insert out, you are not supposed to put the same insert in, because the backside lock goes.
Yeah.
It's one little
So that's a good tip, Raju. Thank you.
Very valid tip.
Yeah. So, and another tip is to bury that nail quite deep than usual in the condyle, because otherwise it tends to, impinge on the insert or the cam mechanism.
Before nailing, confirm the hold of the compound with the bone is good. Otherwise, you will shatter both the condyles separately and the compound will be in your hand.
Yes.
That is the one situation, because it's very low fracture.
So there is now a new implant which has come from Synthes, which gives you a nail plate combination. So you can put a nail, and over that with a jig, you can slide a plate on the lateral side as well as the medial side. That's not yet marketed in India, but it will soon be released, I think, by June or so. So this is the result at 1 year, the right and the left. Okay. She was lost to follow-up. She was from Periphery, but her son, who is an advocate, sent me videos of her with her grandchildren, etc. She was completely full weight bearing and healed well. This was the lateral. So the backbone had incorporated well on both the sides, and she was full weight bearing. I did not have to change anything from the prosthesis. Happy?
So, few comments. Patient is done well. She's an elderly. Her needs are not much. She's predominantly housebound, so she's able to manage with a comfortable life. But if you actually look at the X-rays very carefully, one, there is unequal joint space. The second thing is
but that's
that,
from the beginning. The spacer I did not change.
Yeah, so the other thing is that the knee is slightly in hyperextension, the patella is not sitting comfortably, so probably, the knee is not very stable, but if the patient is managing, there's nothing like success.
Yeah, so this was it. Of course, the story doesn't end there. This is what happened. 2 years later, she came just a few days ago with this. Now what? Chandak sir. So she had another fall in the bathroom. The bathrooms are the bane of this age group, and probably, yeah, so left side had healed well. To my surprise, there was nothing on the left, but this was the right. Now what would you do? Pradeep?
So,
Of course, if the distal fracture is united, we can always remove the nail and maybe replace the problem.
Yeah, so mind you, before you came, she's -4 on DEXA. She's already on steroids for asthma, diabetic, hypertensive, everything. So, if you remove the nail,
So there are
what kind of,
2 or 3 sacral fractures are also seen.
yeah. Anything, Raju, yeah.
Just go back to this. See, basically, this is the neck of femur that's happened. You have to replace it. Now, to replace it, you don't have enough place to go in there. Now, the only way I can see about it, and your point about the knee being asymmetrical is more on the right side, where there's wear of the poly. So I use this scenario. Just go in the knee, open the knee out, take the poly out, take the nail out, change the poly. So I've done that poly bit also. I've stabilized the knee. And same sitting, I would just do cemented bipolar and get out. The whole surgery time would be about 45 minutes plus 1 hour, 2 hour surgery, which would cut down on the. Otherwise, is there any other option?
Any other option?
Can we see the X-ray of the previous one, which shows the distal fixation on the right side? Yeah, okay. So one apprehension, as you're saying, is that the internal splint, which is the nail, is protecting the femur from damage, and that is the reason why, because of stress loading, she is injured on the neck.
Yeah.
So we definitely want some kind of a fixation on the femur, otherwise we are landing up in a third fracture, which is an interprosthetic fracture.
Perfect.
So what we want to
that
do
was a
is
concern.
take the nail off, put in, do a hip for her, and just stabilize with a MIPO plate going up to the isthmus. So
Okay, so a small
with a
stem
change of the liner.
with a plate.
I think I just want to defer you. If it was a stress, it would have happened at the subtrochanteric or trochanteric level. It's a completely independent fracture. It is something which would have happened even if she didn't have a knee.
So she has a nail there, wouldn't have fractured. So,
The fracture talking about would have happened at the tip of within 1 centimeter of the tip.
Chandak sir, any other plan?
It is completely independent fracture. So I think you have a point. I mean, I think you should protect the.
So
he's very well
one
point.
plan is remove the nail, use a standard prosthesis and span the whole shaft with a plate.
Yeah,
Chandak sir, any other plan?
Yeah, I would put something on the lateral side after removing the nail. Or I would put a shorter nail, which goes up to the tip of your prosthesis, if you have that much.
So you will revise the nail
Yeah.
to a shorter
Yeah,
nail
to a shorter nail.
and put a
But
prosthesis.
ensure that there is no space between the two
Okay.
implants. It's a little difficult thing to do.
Jignesh, anything you would do different? Chandak sir?
if we are talking options, just to enumerate, there is another option of doing a total femur, but that's too huge an option.
Yeah. So I removed the nail and this was done by our hip replacement surgeon, Dr. Joshi. So he's tried to go right down up to the plate. What would happen now?
So great looking fixation, the only worry would be an interprosthetic, because without with an unprotected
No, but now he
femur-
has crossed the plate also.
Yeah, so but still, we would definitely like, whenever we would definitely like a very significant overlap.
Okay.
So, I would, if I have to do, and this is just the perfect implant to do cementless or cemented, whatever one is comfortable doing. But would definitely like to, just span a minimally invasive kind of a fixation going up to the top.
Well, I would also wait for that if that happens, or the left side now. So that is all. Thankfully, she has not yet come back.